Welcome again to everybody to Trauma Training Tuesday. We are so grateful that you're here, that there's an audience that cares enough about trauma and other people's experiences to keep showing up for this. It's so inspiring and gratifying. We are so grateful to have Dr. Crista Johnson-Agbakwu here today. She's the executive director of the Collaborative for Health Equity at the UMass T.H Medical School. She's already made so much of an impact in our community in Worcester. I've seen her speak a few times and was so completely impressed. And I know she's going to really drop some important knowledge on us today. Dominica's also here with her. And I don't know if there's anything else you would like me to say by means of introduction to the two of you or to the center, or I can just hand it right on over to you and be quiet myself.
Thank you so much, Amy. I have Dominica as well as Gurutse, two of my colleagues from the Collaborative on Health Equity. I'm so glad that they were able to join us and just appreciate just the impactful work that our team is leading during these, tumultuous times, to say it mildly. And I'm really excited to be in community with you all today on this important topic. And I really am looking forward to our discussion afterwards. And I really appreciate this safe space to have some, deep-seated conversations on this particular issue. I'm going to share my slides. If that's okay. Let's bring it up 1 second. Can everyone see my slides?
We can see your slide. Oh, there you go. Now they're in presenter.
Okay, perfect. Perfect. Thank you so much. So over this next hour, I'm really going to be speaking about how we can optimize trauma-informed care for women and girl survivors of female genital mutilation and cutting. And in terms of my learning objectives, is really to understand some of the historical and socio-cultural underpinnings and epidemiology of this practice, as well as its health impact, and recognize the human rights concerns and factors influencing health inequities and gaps in respectful care for communities affected by this practice, and really apply best practice strategies to engender deeper trust in providing linguistically inclusive and culturally and trauma-informed care that optimizes outcomes, but also promotes the health and healing and wellness of women and girls at risk for or affected by this practice. So I often talk, those who've heard me speak before have probably seen this slide a dozen of times, but it's so important for me to level set, to just anchor my own positionality to this work and just recognize the intersectional identities that I embody and my own lived experience that informs my own work and my own advocacy in this space as I seek to advance sexual, reproductive, and gender health equity, as well as social and restorative justice for minoritized communities. And just a little bit of my origin story into this work. It was during my undergrad years. This goes back, dates me, but it goes back over 30 years now. But I was in my senior year at Johns Hopkins University when I was on the winter break between the fall and spring semester, and I was home. I'm an avid reader of many different novels. This was a fictional novel by the esteemed Alice Walker, and it was on the story now Possessing the Secret of Joy, which is essentially the sequel to The Color Purple. But up until that point, I hadn't actually heard about the practice of female genital mutilation up until then. And obviously this is a fictional novel, but for my spring semester at Hopkins, I took a course on women in pre-colonial Africa, where we had to write a 25-page thesis at the end of that course on any topic relating to women in Africa. And having just, came across this practice, I spent the entire semester researching the historical and cultural underpinnings. And who knew that way back then, this was now 1996, that this was really the beginnings of what later has unfolded to become my life's work and my career trajectory, working in this space and working with communities affected by this practice. And it really shaped, what I've done with my life. And so when I graduated from Hopkins, I matriculated to Weill Cornell Medical College in New York City. In the summer after my first year of medical school, I had the opportunity to work at a nonprofit NGO based in Manhattan that was entitled Rainbow at the time. It was led by Dr. Nahed Tubia, who at the time had put out one of the first publications published in the New England Journal of Medicine that put female circumcision as a public health issue in the national forefront. And Zainabi Yeager was one of her staff, basically her deputy director of Rainbow. And they both took me under their wing. Zainab went on to form her own nonprofit, which still is a pillar in the New York community, New York City community. It's called SOTIETU. It's the Center for African Women and Families, and she truly is a living legend. And literally, I am doing this work because of her and because of her mentorship and her really anchoring a deeper understanding as to, you know, how this practice is embodied for women and girls directly impacted. And she was doing a lot of work and continues to do a lot of work in New York City to really champion the health and human rights for girls and newly arrived African immigrants in the New York City metro area. You know, when I graduated from medical school, actually, that was what really grounded my determination to pursue OBGYN as a career. And I matched into residency at George Washington University in Washington, D.C. And those of you who are familiar with the DMV knows that it is truly the mecca and melting pot of everything multicultural, huge immigrant communities from all over the world. And where I trained, we served 3 hospitals, teaching hospitals that were in not only Washington, D.C., but Maryland and Northern Virginia, all of whom we served populations that were impacted. Large West African patient population in Silver Spring, Maryland, a very large East African patient population in Northern Virginia. And so this was really the first time I actually encountered patients for the first time. My work in New York, when I was a medical student, I did a lot of public health outreach, working with Dr. Nahed Tubia and Zainab, doing a lot of public health education and outreach among newly arriving families coming into New York. But now when I moved to Washington, D.C., in my training in OBGYN, this population became my patients. And that's where I really kind of stood on my soapbox and really advocating for best care and practices for newly arriving communities amidst a medical environment that really wasn't quite culturally congruent or linguistically congruent, to say the least. And I forged a specialized clinic at the time of patients that I served who were affected by this practice. And really, that's where I really became emboldened in terms of my own advocacy and support for best practices for helping women. And back then, Dr. Janice Blanchard, which is the importance of mentorship, is so crucial. You know, she is still an emergency medicine physician at George Washington University, and she saw my passion around this. You know, and she took me aside one day and nudged me. She said, you know, what do you plan on doing when you're done with your residency? You know, she is the one who truly inspired me to think outside of just, you know, what I saw all around me, you know, instead of just hanging up my shingle and just opening up a practice or joining a practice to, you know, practice OB. She kind of broadened my view to say, hey, you can actually take this quite far in terms of gaining the necessary skills to advance work in this area from a policy standpoint, from a clinical care and research standpoint. So she's the one who inspired me to pursue the Robert Wood Johnson Foundation Clinical Scholars Program, which I ultimately did pursue at the University of Michigan. By the time I found out about this fellowship program, I was already a chief resident. And so I had a gap year that I had to fill, that I matriculated to UCLA, where I did a sexual medicine fellowship for a year, which was actually very instructive because I was pitching this from the angle of, well, I want to be able to improve sexual care and outcomes, addressing psychosexual sequelae. This would probably give me important key skills that I'd be able to apply to this work. And so I had a, you know, detour through UCLA before I matriculated to the University of Michigan, where I spent 3 years working with large Somali immigrant communities in Columbus, Ohio, a 3-hour commute from Ann Arbor, but really foundational for me to do crucial, groundbreaking work in the space, working with over 500 women impacted by this practice and looking at barriers to care and health inequities and issues with trust. And that really was what launched what has become my career trajectory in this work. So when I finished my fellowship at the University of Michigan in 2008, I was able to land my first faculty position out of training in Phoenix, Arizona, which is where I spent the next 15 years building refugee women's health programming for newly arrived migrant families from all over the world. We actually served women and families from over 70 countries across sub-Saharan Africa, the Middle East, and Southeast Asia. You can see a reflection of some members of our team who are community health workers, who are literally the trusted messengers, who had shared lived experience of forced displacement themselves, who spoke multiple languages, certified medical interpreters, who really connected the dots in terms of linkages to care. And in so doing, we're able to serve over 16,000 patients at our public safety net health system. And even though I've left this community 2 years ago, it continues to flourish and is a pillar in the local Phoenix community. And in that realm, I created a niche for women with FGMC. That ended up comprising about 20% of our patient population, largely East African women from mostly Somalia, but Sudan, Ethiopia, Eritrea, Djibouti, basically the Eastern Horn of Africa was really my clinical niche, and I provided a lot of care and surgical care for this community. I also want to anchor that, there's important context with my own personal story. And so many of you see my name is hyphenated. Johnson-Agbakwu is my married name because my husband is from Nigeria. He's Igbo and is from a part of the country where FGMC has been prevalent. In fact, his paternal grandmother, his aunts, his father's twin sister, all have been affected by FGMC. It has been a deeply cultural embedded practice for years. His mother did not come from a community where FGMC was practiced. And so his only sister, obviously is not impacted. But I'm just imagining, I have two daughters. You can see this is from a few years ago, but my daughters are currently age 5, soon to be 6, and my oldest is 10, which are critical years, as you will see, where FGMC is commonly practiced in cultures where this is which is common. This is a common age range where girls undergo this practice as part of cultural traditions. And so this has a huge, relevance to me, because imagine had I been born in a different era and my kids born in a different era, generation, right? Married into a family where this is common, this would have been potentially their story as well. So this has important relevance. That these are not just numbers and statistics, but lives and families. And so I want to just start us off with just a few questions, just 3 really quick questions, just to level set to see where we are. If you could scan this QR code, I'm going to ask Dominica to drop this in the chat, a quick link to just 3 very quick questions to just level set on just what is our audience's baseline knowledge about this practice or prior engagement in this, in caring, serving clients or patients impacted by this practice. So if you could please go to the link or scan this QR code. I'm going to stop share just for a minute so that Dominica can bring up the actual platform really quick. And just to see where we are as an audience in terms of prior
You didn't give us enough
engagement.
time. We need more time. We need the QR.
Yeah. Oh yeah, let me go back.
Yeah, we need the
It's
QR
also
code.
in the chat.
The link is
The link
also
is
in the chat.
Oh yeah,
that way.
perfect. Thank
Oh,
you.
okay.
Sorry, I was a little too fast there. Sorry about that. Thank you though. So it's just some really quick questions. The first one being, have you had any previous training opportunities on FGMC? I'll just wait a few seconds for people to be able to respond. The
A couple people said they were having trouble with the link. I didn't have trouble, but
I see 19 people on, 20 now.
okay, great.
On the actual site, I could see it here.
I think that was people were having trouble with the link getting into the workshop.
Oh,
got it.
Oh.
Got it. So,
see
yeah,
some
I'll just
thumbs
give it
up.
a little bit of time. Yeah, wonderful. Great. And yeah, there's just three really quick questions. And I think when we have enough responses, I'll ask Dominica to share what we see, just so that we could all just
Do
have
the
an
reveal.
idea.
Oh, I see now 22 people have jumped on.
Yeah.
A couple folks still getting on there.
Dominica, do you think maybe you could resend the link for those who might have
Oh, yeah.
just joined? Yeah. I'm gonna have the
Absolutely.
link to the
Let me go
Mentimeter.
ahead and send that to everyone. Link for survey. Okay,
Thank you so much.
of course.
So yeah, there were three really, really quick questions that you could just complete. And then we'll proceed.
Shall I do a reveal?
Sure, sure. So the very first question was, have you had any previous training opportunities on FGMC? And clearly, I'm so glad you're here, because it sounds like this will be the first exposure for many people in this audience. So I'm really, really grateful that you took the time to be here today, and that this recording will be available.
Oops.
Yeah, great. Thank you so much, Dominica.
Next
So we
one.
can move on to the next question. Yep. And how often have you encountered FGMC in your line of work? So clearly, majority are not really sure, which is fair. Yeah, and many have never had any encounter, and only one frequently. So this is also really instructive for me to know. I'm so glad we're here and doing this work here in Central Massachusetts, because I think there's a great opportunity to really impact, knowledge and competencies here in the region. So this is really fantastic for me to glean this insight. And then perhaps you can go to the last question, Dominica. Thank you so much. Okay, are you aware of resources to support FGMC communities? And so exactly, I'm so glad. I will definitely make my slides available, because at the end of my talk today, I have a plethora of resources, and I'm sure we'll continue to build and add to this as we connect with local community organizations and efforts that are happening here in the region. So it's really good to have this baseline knowledge of what's available, what people are aware of in this space. So thank you so much for taking the time to go on that Mentimeter. So I will go back and share my slides, and we'll pick right back up again. So thank you for doing that. This has been really helpful for me to know. All right. So let me just now dive right in and talk about some of the historical and cultural underpinnings of this practice. And so you may have heard there are many different terms that are used. The World Health Organization uses female genital mutilation, but often in working with communities, especially a lot of the communities that I've worked in throughout my career, that in of itself can be a jarring term. And so when in talking and training and teaching on this topic, I always often say, what's safest is to use whatever terminology is most familiar to the community, the client, the family that you're engaging with directly. I just say, what do you use to refer to this? What are you comfortable with? And that's the term that I use. But there are so many different ways in which this practice has been coined. in general, we're very patient-centered and community-facing efforts. I very much lean on using whatever terminology communities most identify with. So the official terminology by the World Health Organization, though, is any procedure that involves partial or total removal of external female genitalia or other injury to female genital organs, whether for cultural or non-therapeutic reasons. And so over the millennia, there have been many.
I missed my 3-day deadline.
Oops.
Please mute. Perfect. Thank you. So over the millennia, there have been many views and perceptions that have justified the preservation of this practice over, which varies based on region and ethnic group and by the type and severity, which we'll learn about. But you can see, as shown on the slide, it's often a rite of passage into womanhood. It can imbue a sense of belonging to one's community, social status, family honor. It's been thought to be aesthetically pleasing, to ward off bad luck on evil spirits, that it ensures safer childbirth. Again, these are just ways in which this practice has remained deeply entrenched. And for some, this may actually fulfill a religious requirement, although, globally, it's not to be, it predates the Abrahamic religions, Christianity, Islam, and Judaism, but you'll see as throughout my talk that that there may be areas where there are strong religious associations with the practice. But when you think about a young girl growing up in a community where this is part of the culture and part of the social norms, that it's not unusual to find young girls might actually want to undergo this practice or beg their moms to undergo so that they are not vilified or ostracized or stigmatized by not conforming. And so this, as you can imagine, can really be quite a challenge, especially in the context of migration and moving from a context where this might be normative to, say, a context such as the United States or the UK, where it's highly stigmatized, that this can certainly cause a lot of psychological concern and emotional distress. And these are some of the things that I'm hoping we could talk about further too when we enter the Q&A. But these are just all of the many different ways in which this practice has been justified across the millennia. And when you look at this is actually a global practice. It's common to just think of it because of all of the news and sensationalizing that it's just focused on sub-Saharan Africa, but it's not, in fact. It's quite global. In fact, over 230 million women are affected around the world, encompassing at least 92 countries. And yes, we do see a very high prevalence throughout regions of sub-Saharan Africa, but we have also learned that in regions of Southeast Asia, also very highly prevalent practice occurs. And then in migrant communities, North America, Europe, Australia, where impacted communities have migrated. You're still dealing with the impact, the physical and psychological impact of having undergone the practice, but also concern for communities who may potentially still be at risk. And so this is truly a global practice beyond just the continent of Africa, which tends to have the predominant attention. When you look at the US context, we have 5 metro areas in the United States where you have about 40% of women and girls either at risk or living with the impact of this physically and psychologically. And that's New York, the Washington, D.C. area, Minneapolis, Minnesota, Los Angeles, and Seattle. And the reason why I say at risk is that where you see the little X there is that, and this is something we can talk about further, is that we have evidence that have come up in recent years from legal cases, but also we have indirect estimates from data that's extrapolating on migrant populations from regions that are high prevalent. But then it's really hard to tease out. We need better data to truly examine who and how many are at risk, which is why that we need to kind of clarify this. And I'll talk about it further when you think about mothers who have come and how old their daughters were when they came to the US, and the concern around vacation cutting in terms of population still at risk. And so we'll delve into that. But we clearly see that there are 5 key metro areas around the country where you have among the highest prevalence rates of communities impacted by this practice. The CDC published some data updating statistics from prior reports estimating, and this is published back in 2016, so already this is dated, but upwards of 500,000 women and girls impacted by this practice. And when you think about it in context, that's 3 times the number of all incarcerated women in the United States. That's more than the population of Atlanta. And so this is truly a public health issue that deserves further attention and research. And when you look just across the spread of the US, where some of those populations reside, we see clusters. We have huge East African populations in the Minneapolis-St. Paul area of Minnesota, as well as Seattle, Washington, and Columbus, Ohio. So where you see populations track in terms of migration, it actually also patterns the types of cutting that you might encounter as well. And you'll see this as I go into this in further depth, but for East African populations, you have higher prevalence of more severe forms of cutting. And then when you look more in Western African communities, you have more type 1 and type 2, which are milder forms. But then what we don't see reflected are other communities outside of the continent of Africa, such as Southeast Asian communities, is really not reflected in a lot of this data. So we really need more data on understanding communities impacted across the country. So I am going to show a short clip, which I absolutely love. Maria Taher, I believe, who's on this call too, I hope, who is the founder and CEO of Sahel, which is a NGO that has done a lot of work domestically and internationally, raising awareness about FGMC and combating the practice. She led a digital storytelling effort a number of years ago, and the link is here as well. In the end, as part of the resources, you'll see that as well, which is really embodying the lived experience of women impacted by this practice. And so I have just a few of these clips that I've interspersed throughout my presentation. And this is one of the first ones I want to share that really anchors some of the cultural underpinnings around this practice that I think is so best reflected in the voices of impacted communities directly. So I really appreciate the work she's done around digital storytelling to really elevate and centering the voices of communities themselves. So I'm going to just play this. It's just a couple minutes, but really helps to anchor our discussion.
The day my friend told me she was not cut, I was so shocked. I was 19, she was 21. I told her that because she had not been cut, her prayers and fasting were not accepted in our faith. This is what people in the community had said to me. I also started looking at my friend with new eyes. We were told the girl who was not cut would become loose and run madly after men. We were told the organs of the genitalia grow long, making the girl walk with legs wide apart to avoid her thighs rubbing her elongated clitoris, and that she would smell bad. I often pretended to be tying my shoes so I could watch and see if she did walk that way. But there was no sign of this. She was not smelly either. 14 years later, I got the correct information. Female genital mutilation in all its types has no basis in Islam. I was liberated from the lie that it is a requirement. I decided to say no to FGMC. I took a position at a reproductive health organization to end FGM. When I was blessed with a daughter of my own, I knew she was a gift for the work I was doing to end this cutting. But I was not prepared for the challenges. Many relatives told my daughter, "You are going to smell. Snakes will grow down there if you're not cut." I got tired telling them to back off and send them packing out of my house. I felt like everything I told my daughter about how I would protect her would be overtaken by what others said about her not. Shut the fuck up! With all of this, she was even growing to hate her body. It hurt me to see her.
Man, such a body ass up, boy.
I ended up leaving Kenya and moving to Canada to protect her. I may have saved my daughter from the physical pain of FGMC, but I could not save her from the hateful words of those who still believe in this practice. I could not save her from the verbal cut.
Great. I would ask for everyone to please mute if you haven't already, just so that we could minimize any interruptions, but thank you so much. So yeah, we could certainly talk about this further during the Q&A, but I really just wanted to use that example by Marianne Abdikadir just to showcase some of the community pressures that and the impact of voices from family, community members that have a strong bearing on women's decision-making or their regret or feelings about circumcising their daughters. And that was a profound illustration of that we can certainly talk about further. So let me go over just the classification scheme. And I realize this is not a clinical audience, so I don't really have visuals that I usually include in terms of actual photos, but I'll show some sketches. But just broadly, there are 4 major categories with subtypes within each one. That types 1 to 3 have increasing severity of cutting in terms of the tissue removed or the tissue that is injured. Whereas type 4 is a grab bag of all the other kinds of procedures that can involve any pricking or scraping or pulling or burning of the tissue, but do not fall into the regimented 1, 2, and 3. And I must also add that throughout the literature, they may refer to the clitoris as being completely cut out, but physiologically, anatomically, it's impossible to cut out the entire clitoris because it extends several centimeters within and deep within the tissue. But what is really occurring, and we have documented that using MRI imaging, is that it's really the tip of the clitoral glands. And this has huge implications on how we counsel our patients around sexual function and sensitivity. And a lot of this, even though we're removing different degrees of tissue, says nothing about the psychological harm. And that's something that often gets left out in terms of the psychological consequences, regardless of the type and severity of cutting. So this is just from the World Health Organization's, their guide. Type 1 is technically the mildest form that involves the hood of the clitoris or that tip of the clitoral glands. And there are 2 subtypes within that mild category. When doing an exam, when I teach students and physicians, often this is the type that can be easily missed if you're not carefully inspecting the vulva. Type 2 is an intermediate form, so it doesn't involve any stitching and closing of the actual tissue, but more tissue involving the vulva is removed. And there are 3 subtypes within this intermediate form. And you can see in terms of what's colored on the diagram, involves increasing amounts of tissue in terms of the inner and outer lips, the labia that can be cut, as well as the tissue around the clitoris. But again, no stitching actually happens. Whereas type 3 is the most severe form because in addition to cutting varying degrees of the inner and outer lips, it actually also involves actual closure of the vaginal opening. The edges of that cut tissue are then reapproximated and sewn together to cover the opening. And that leads to a very small opening for urination, menstruation, penetrative vaginal intercourse. And so this is where you see in the literature predominance of most of the publications focus on type 3, but it's important to recognize that there are 4 types, but increasing severity in terms of the actual tissue that is removed. And so the immediate complications we don't necessarily see in the US context unless it actually occurs in the US context. But what you see in global context tends to be bleeding, infection, and if extreme can lead to, unfortunately, the death of the child. There can be shock, genital swelling. You can imagine this is often not done with anesthesia. And so the practitioners may not necessarily be medically trained. And so there can be a lot of risk of injury to structures lying around the vulvar tissue. And we see more predominantly the immediate impact most commonly in the global context. But what we do see in, say, the US context are some of the long-term morbidity which relate to obstetrical care, especially during childbirth. And due to some of the lack of competencies among providers, this is not just OBGYNs, but family medicine doctors who may perform childbirth in terms of competency. Well, how do you manage the labor of someone who may have been circumcised or undergone genital cutting? And then you also see long-term gynecologic concern relating to infection, recurrent infections, whether it's urinary tract infections or other genital tract infections. Regarding HIV and hepatitis B and C, these other bloodborne sexually transmitted infections, that's more theoretical, although some studies have shown association, but what we are lacking are some of the large epidemiologic trials to really truly show clear linkages between some of these infections and transmission to women and girls, namely relating to the type of instruments or whether these instruments are shared across groups of girls who might be cut at the same time. So more research is needed in that area. There's been a host of work done examining sexual dysfunction, especially pain, decreased sensation, impact on the ability to achieve penile vaginal intercourse, especially for women with more severe forms like type 3. And then, of course, the mental health impact. And as I said before, this is irrespective of the type and severity. Across any form of cutting, there can be psychological impacts that can be quite profound.
Shut the fuck up, bitch ass. Can I slap your big nose head out, boy?
Could we
Yeah.
please mute? Please, is there ability
Bro.
for us to mute?
Shut your cradle head ass up, boy.
yeah,
Like
It's
that.
Zoom bombing.
Moving on to defibrillation. This is a term you might come across relating to women who have type 3, which is the more severe form involving fusion of the vulva. And this is a surgical procedure that we do to help relieve a lot of the complications that women experience. And there are a host of benefits for relieving that vulvar fusion that could help improve urination, improve pain, say with menstruation. It can help with sexual function in terms of pain experienced during intercourse, and of course can help with facilitating childbirth. And of course, the nuance is the timing of when it's appropriate to perform this procedure, especially when we're dealing with an adolescent, and there might be cultural considerations in terms of perceptions in the community that we need to consider in terms of stigmatization
Alex, you
of
a
the patient or the family. We also want to talk about how do we counsel our patients, because if you can imagine someone who's had type 3, where they may have had fusion of their vulva, their urination may take longer, and they might have lived for most of their lives, right, with a very small stream of urine. And so it's so important as a provider to talk about what to expect after the procedure, because their urination might change. And so to think about the impact on genital self-image is something that doesn't get talked about enough. And we can talk about this further in terms of what if women have strong cultural pressures to reclose the scar after delivery? What do we do in those circumstances? And we can certainly talk about that later. This is a video that is, you can scan the QR code. If we have time later on, I can come back and show the video if there's interest, but you can please take a picture of this and scan the QR code. This is a important resource that has been developed by our colleagues in Europe, in Belgium, that is being used across the world. In fact, it's available in 9 languages and is really culturally appropriate and, of course, linguistically inclusive, that provides really great resources for patients who might be considering defibrillation procedures. So let me just talk about some of the legal and ethical considerations. Many of you may have heard about the case in 2017 that hit not just national but international headlines of a physician, emergency medicine physician in a suburb of Michigan, who was alleged to have performed genital cutting procedures on up to over 100 women over a 10-year period in Livonia, Michigan. And this was the case that kind of uncovered the Pandora's box of practices outside of the continent of Africa involving the Daudi Bohra community in terms of a traditional practice that is very much closely aligned with the Shia Islamic faith. And the way in which this case kind of blew open was a young girl who had visited this clinic, had undergone cutting, had a monogrammed glove, a white glove that she was wearing at the time. She had removed one glove and placed it in the back of the examination table at the time of this procedure. And then when she returned to her home in another state, she then reported it to the authorities. And to validate her story, they said, "Go find my missing glove." And when they went to this particular clinic and they went to the room where this was thought to have occurred, they actually found the matching glove with her initials on it. And that's what kind of blew the original case. And of course, this resulted in a change in the US law. When you think about the timeline of US legislation, this is going back to 1996, when Congress first passed the Federal Prohibition of Female Genital Mutilation Act. And as you can see, over the years, there's been resolutions passed by the United Nations. There's been closure of the loophole relating to vacation cutting in 2013. So there is prosecution for female minors who are brought out of the country, say on family vacation or other holiday, to protect girls from undergoing this practice during these trips. There has been resolutions introduced in the House of Representatives. This was in 2015, but really in 2019, when the federal law that was on the books from 1996 was thrown out, that really, as a result of this case, that really resulted in concerted efforts that landed the new law, the Stop FGM Act of 2020, that officially became law in January of 2021, which increased the criminal penalties for performing FGM on a minor and expanded the scope of punishable offenses. And so where we're at now, we know that FGMC is a form of child abuse, and it's prosecutable in every state under existing child abuse and sexual assault laws. Different states vary in terms of the addressing vacation cutting, as well as FGMC as grounds for asylum. And for many years, especially my years when I was in Michigan, I worked with local immigration attorneys, writing affidavits on women seeking asylum in the United States, where we were using testimony around their prior exposure to FGMC as grounds for being able to stay in this country and avoiding deportation, especially if there are threats to their daughters. And so we were very successful in winning a number of these cases over the years. But yes, we officially have a federal law on the books as of 2021. And where we are current state is that 41 states including the District of Columbia, have state-based legislation in addition to the federal legislation relating to FGMC. Of course, individual state laws may vary in terms of, as I had mentioned, the ban on vacation cutting, the inclusion of female minors in addition to adults, as well as parents and guardians being penalized, even if they are not the ones to perform the actual FGMC. And also certain state laws may include mandates for community education and outreach. So where do we stand here in the Commonwealth of Massachusetts? You can see that we have a law on the books as of August of 2020, and it provides a statute of 6 years, a statute of limitation, and imprisonment from anywhere from 2.5 to 10 years with a fine up to $10,000. It does include provision for vacation cutting, which is banning travel outside of the state to undergo FGMC. And it does, in fact, include provisions for community education and outreach, which I am really excited to be working with Saheo on, as well as the End FGMC network in increasing work that we're doing here across the Commonwealth addressing FGMC. And so I wanted to kind of also touch upon very briefly some of the ethical conundrums. Over the last couple of decades, there's been an explosion in demand for labiaplasty. And this is just an example of one of countless practices across the country that tout improving your self-confidence and genital appearance by undergoing labiaplasty. The issue is this double standard. Are we, and just to push the envelope here, in one breath, while we are clearly raising attention and the need to protect women and girls from cultural practices, there's been an explosion of genital modifications involving demand for labiaplasties across the country in recent decades. And even in our own literature, this is one of our prominent OBGYN journals. So, recent estimates of the demand for labiaplasties, particularly among minors, and that's why I really flagged this article. This was just published in the last few years in terms of high request among adolescents and young women. And in this particular article, it shows about 20% of all cases of labiaplasty are actually being performed on girls, on minors under the age of 18. And so this double standard of requests for genital modification for some women, but other women, this is deeply stigmatized. Is just something that really we need to talk about in terms of informed consent, as well as a double standard of how we're perceiving one kind of practice versus another, and is really anchored around genital autonomy, patient autonomy, and consent. Another ethical scholar that I would urge you all to kind of look into is Dr. Brian Earp. He's based in the UK at the moment. He has done an enormous amount of work in this space in terms of really delving into the ethical complexities of childhood genital cutting and really looking at where do we consider the autonomy of the child, regardless of their gender. And this is just a reflection in terms of the lack of a clear and obvious binary in terms of genitals, and the fact that genitals come in all shapes and sizes. And there are clearly religious groups that adhere to genital modifications on religious bases. But where do we draw the line in terms of what is clearly either a religious or cultural mandate that is acceptable, say, to alter the genitalia of boys? But when do we then consider this for girls? Looking at how do we protect, and obviously this is much deeper because it involves issues of empowerment and educational opportunities and gender-based violence more broadly. But it really is something that I'm hoping we could talk further in the Q&A in terms of just sex-based distinctions are truly untenable, because we have to consider the broad spectrum of gender identity, including intersex, and how do we really defend genital autonomy for all minors, regardless of gender. And what I really love is this quote from Brian Earp, where he really, really anchors it around consent and the lack of consent. And how do we protect all children from unnecessary harm? Is that we need advocates of children's rights to argue that it is the lack of consent for non-medical reasons, which is the moral and ethical issue, rather than where along the spectrum of a child's sex or genitals they might fall. And so this is an area that is deeply and hotly debated even now, and it really also has reared its head most recently with this current administration. And I really appreciate the End FGMC network for putting out the statement relating to the most recent executive order that really confounds the real and serious issues of female genital mutilation and confounds it with efforts that are also absolutely crucial and important in terms of preserving gender affirming care. But the melting this as one singular issue is so dangerous because it further stigmatizes and harms communities. And we really need to, I'm so glad the NFGMC called this out in terms of what are ways that we can be perpetuating harm on communities that are already marginalized and stigmatized. And this is something we're actively dealing with right now. And so there are clearly pervasive gaps in trauma-informed, respectful care. And most pervasive right now, in terms of the so many threats that we are navigating in real time here in this country, there's profound distrust among communities. There's fear that has, and stigmatization that has led to delays in care seeking, refusal of care, and ultimately resulting in adverse outcomes. And so what we really need to strive towards is how do we close a lot of these gaps in enhancing the competencies and knowledge of our community, of practitioners, of not just healthcare clinicians, but we need to look at how do we empower our school nurses? How do we engage with law enforcement? How do we build strong alliances with our social workers to improve not only their communication and clinical skills, but recognizing the unique needs of families and communities, women and girls impacted by this practice or at risk for undergoing this practice. And recognizing that this is a dynamic tradition that's in transition. And we have to understand some of the dynamic processes that communities are navigating in real time as they adapt to new norms and beliefs in the context of migration, relocation. Many are coming from communities where FGMC is a cultural right that impacts one's marriageability, where there's strong community pressures to conform to cultural traditions, but also now looking at this in the context of, say, living in the US or in Canada or in the UK, where this is clearly, highly stigmatized, in fact, even criminalized because it's a human rights issue, an issue of gender-based violence. And so as communities wrestle with their identities as they're moving from one context to another, we really have to understand that this is a dynamic and evolving process. And what we're seeing, say, coming out of Europe is that there's this, what the literature has now unpacked is that there's a sweet spot around 4 years where communities residing in their host country may adopt the norms and values of that host nation in terms of changing views and attitudes that conform with the ideals and values of the new country that they're now identified or living within. And so we need to look at this more carefully and really examine this, especially in this current context where there's so many threats to communities that are intersectional. A lot of the work that I did in my prior role in Phoenix, Arizona, working with large communities impacted by this practice, I examined experiences of discrimination, and I was able to coin what we now know as a quadruple jeopardy of intersectional relationships, whether it's one's racial identity, gender identity, religion, migratory experiences, as these colliding and really influencing a lot of the adverse health consequences that we are seeing among migrant communities impacted by this practice. One of them that I want to highlight is this egregious case in Sweden. And I have the QR code if you want to snap a picture of that, if you want to actually see this horrific YouTube video. But it really looks at this intersectionality of race, class, gender. And we have the Swedish Minister of Culture. This was back in 2012, which was celebrating World Art Day, and posted on Facebook this horrific parody of an African woman in the form of a cake. You had a visual artist in blackface, which in and of itself is pretty traumatic, and bare-chested, breasts exposed, undergoing genital mutilation. I mean, this was
Mira, esa hermana
horrific.
se sintió. Esa hermana que vino
Where
de Nigeria.
as the
Ella,
cake was being sliced, you see that the visual artist, when you actually watch the actual video, is like screaming out in pain. But look who's watching. It's a sea of faces, all white, smiling, snapping pictures at the pain that this visual artist is demonstrating. And in fact, this person is being fed the very cake. I mean, that's auto-cannibalism. I mean, this was so horrific on so many levels, profoundly horrific, but truly encompassing this othering of Black women's bodies, right? And it really, really looks at structural racism at its worst, and the implicit bias and racial stereotypes and cultural imperialism that perpetuates harm and discrimination that's interwoven within our societies and have profound impact on the health and well-being of affected communities. And so the other thing I wanted to kind of level set it on is that a lot of times the literature focuses on type 3. Granted, that is the most extreme form of cutting that has the greatest debilitating impacts on physical health. But I also want to put this in context. And when you think about the patterns of migration, in fact, those populations that encompass type 3 represent only 12, not more than 20% of all forms of cutting. The majority is really type 1 and 2, and in fact, type 4. And we're not even talking about some of the psychological impacts that don't get enough attention as to the physical impacts. So we have to really think about how we are framing this practice and recognizing that there are important trends in terms of communities abandoning this practice that, granted, it's been decades of progress. This is 30 years of progress. When you see on the left-hand side, the percentage of adolescents that have undergone FGMC, there are variation in the progress across countries. So on the farthest left, you see those countries that have had the greatest drop in prevalence for adolescents are like Ethiopia, Sierra Leone, Liberia, Tanzania, right? Nigeria, Kenya, Iraq. Whereas some countries that have made some progress include Guinea, Sudan, Djibouti, Egypt, for instance. And then countries with very little progress over 3 decades include countries such as Somalia, Mali, Gambia, Senegal, etc. So we clearly have tremendous work to be done. But what's also important is that we think about the ways in which we can perpetuate harm, especially the unintended harm. One of them I want to highlight is Operation Limelight, which is a multi-agency group working to with U.S. Immigration and Customs Enforcement that was profiling passengers departing at London Heathrow and other airports coming from countries where FGMC is prevalent, and providing educational pamphlets, but also, questioning and interrogating families. And while we definitely need to protect, young girls and women and families, we also need to look about, especially in this current environment, what are the unintended harms, especially when you think about some of the intersectional identities that many of these communities face, and the profiling, which is often racially profiling of certain groups, that can certainly have significant harm, both psychological and familial, in terms of family separation, etc. Especially in our current era, we need to really think about carefully in terms of ways that we can avoid unintended harm while protecting girls at risk, and providing trauma-informed care for affected women. And one of the things is that we need better data to help identify girls at risk, especially if it's a family coming from a prevalent region of the world, You have to look at, well, are the mother and siblings also affected? Did the girl immigrate to the United States as a young child? Was she born in the United States? In terms of understanding what are the inherent risks and really making sure that we're equipping our social workers, our school nurses, our clinicians, our law enforcement agents, right? How do we work together to raise awareness so that we can better support our families and our communities in ways that are culturally informed and culturally congruent, but avoid further stigmatization and trauma. And so that's what I'm hoping that we can do. And there's been a tremendous work already done across the Commonwealth that we're hoping that with the team that I'm working with SAHEO and the NDFGMC network, that we can really elevate and accelerate more of this work across the Commonwealth. I want to share this other voice from the digital storytelling work of SAHEO. And this is the voice of Sharon Abdul Rahman in terms of what this might look like in the clinical realm. So I'm just going to share that really quick.
Four, 7, 11. She is held down, performed by older women. She lays bound and unable to walk. Her pain lasts for days. It's not foot binding of yesterday. It's the current practice of female genital cutting. While happening in many parts of the world, it is foreign to me. And now she sits waiting for my professional care. I am an OBGYN. I don't remember any medical school lectures about this. I don't have a template or an algorithm. I was taught how to do a pelvic exam, and over the years, I have spent plenty of time looking at the cervix and palpating the uterus. But that one erectile organ with more nerve endings than your tongue or fingertip, with the sole purpose of enhancing sexual pleasure, often got overlooked. Today I look. When there's evidence of female genital cutting, there is that awkward moment. Does she know? Does she know how she's been altered? Is she waiting for me to say something? If she tenses, I stop. If she makes eye contact, it's okay to continue, okay to talk. At the end of the visit, we both exhale. Feeling knowledgeable, I traveled to Somaliland. There, like an onion, layers of complexity started to peel back. She was 21, being prepared for surgery, but the Foley catheter couldn't be inserted because the opening from her type 3 cunny was too small. The OR nurses were matter of fact. They say to her, "We will open your scar." She whimpered. Was she crying because of pain? Was she crying because she wanted to stay untouched? In that moment, I remember one woman's description of female cutting as clean. I caught myself. I was ashamed. How could something so unnecessary, so traumatic, be that? Back in the U.S., the layers of complexity continue to peel back. An African woman, the subject of a play, asked, "Who are you to judge us? Don't you perform male circumcisions and labioplasties?" I pause. I am an OBGYN, and here she sits, another woman waiting for my professional care.
So I really like that video because it really anchors, that story. What do we need to do as practitioners, as public health professionals, as social workers, as nurses, as community members, right, as community organizations, as legal practitioners working to support families and girls. And what it necessitates is a multi-pronged strategy of us working across the aisle, working very closely with our community partners and affected communities, nurturing trust while we are advancing research for better data, while we're providing trauma-informed care. And this is where, when we think about engaging in research, it must be done in a way that promotes equitable, trust-based partnerships with communities, that centers the voices of those with lived experience, that amplifies local champions, that nurtures safe spaces that are inclusive, that are bidirectional, where representation is everything, right? And so those are some of the things that I've done over the course of my career that I'm working with teams here in the Commonwealth to advance as we seek to increase that community engagement and that trust. And it necessitates multiple stakeholders. Maybe it's men, maybe it's youth, maybe it's our elders, religious leaders, our social service agencies, resettlement agencies, right? I've already talked about the importance of our school nurses and working with our legal partners and law enforcement, but also looking at this within the context of promoting gender equity and economic empowerment and stigma reduction, while we strive to address some of the other issues relating to gender-based violence and interpartner violence and educational opportunities for women and girls too. So there are so many ways in which we can really impact and support communities in taking a holistic approach that's trauma-informed. And while and this is something I always harp on in terms of taking an asset-based strengths approach, because it's so common to just focus on the horror or the stigma of the physical and psychological impact of this practice, right? And the impact on, and the traumatic impact, obviously, on families and girls. But I also take a strengths approach in terms of look at the cultural vibrancy, look at the strength and resiliency that these communities bring, and how can we harness that in ways that nurture safe spaces anchored in trust and mutual respect, radical empathy and dignity that necessitates effective communication, where we champion the voices of women and girls impacted in a way that advocates for them and empowers them and honors their autonomy. And cultural humility is key. And how can we take a non-judgmental approach that is trauma-informed, that's respectful, that's patient-centered, that's confidential, and engages the community in a way that reduces stigma, right? So I'm going to share this last video as we conclude, and then just showcase some of the resources that are available across the Commonwealth.
I was 18, and I was having my first pap smear. A pap smear is never really something to look forward to, but this was stepping over my boundaries and resurfacing everything I had worked so hard to forget. Hesitant at first, I eased into the vulnerable state, uncomfortable for anyone to be in. Trusting the stranger to examine my deepest, most private parts, reminders of my painful childhood. As she felt around the outside of my vagina, she said, "What is this?" At first, she naively stroked my lesion, but then her touch became invasive. It did not feel like medicine anymore. Her touch paired with the curious tone of her voice that expressed both concern and ignorance sent shivers down my spine. I thought, she now knows. I wondered, will these feelings resurface every time I undress before a doctor? Every time I decide to tell someone I'm getting close to about what happened to me. Every time I share my body with a lover. I have not had a pap smear since. I should not have to face these questions. No woman should.
Again, I want to thank Saheo for just their groundbreaking work in elevating the stories of women and their lived experiences, embodiment of this practice. And so for us as community leaders, as advocates, as practitioners, you know, there's so much we can do to, as we move forward in terms of how we engage with women and girls and families, in terms of how do we create an environment that's safe and inclusive and patient-centered, that elevates a patient's desires, but also in the context of understanding what this means in relation to her family, her own decision-making, and her own autonomy. Bearing in mind that there are legal implications, there are community implications, there are partner implications in terms of when is the best time to intervene and what would that look like, what are the patient's desires. And some of the work that I've done has been to recognize that these women and girls live within a larger societal construct of social determinants of health, that as we seek to increase our trust and engagement with communities, making sure that it's done so in ways that communities address distrust that might be inherent in the way in which they might perceive healthcare. How do we reduce stigma, but also empower women and families in their autonomy and decision-making about their bodies? How do we address issues of language barriers and the need for appropriate interpretation? How do we address gaps in insurance coverage or lack thereof? Other structural barriers such as transportation to and from these appointments. How do we make sure that we don't vilify the partner? Oftentimes the partners get a bad rap. In my experience, the partners are the biggest supporters of their wives, their sister, right? Their relative, because they can really be an anchor of support and education that can impact daughters, wives, other family members. And it's so important to not vilify them, but bring them in and bring them into the conversation, bring them into the discussion, bring them into the decision-making. For providers, what we're doing today is one step that I'm hoping is one of many more work that we'll do in terms of working across our health systems and community organizations to make sure that our providers understand and have the core competencies that they can not only provide the kind of care within their scope of practice, but also deal with some of the ethical dilemmas. Many of them you've saw me touch upon in this presentation alone. And recognize that we cannot be silos. We really need to step outside of our comfort zone and work across the aisle with sexual health educators, with psychologists, with pelvic floor therapists, with clinicians across different specialties, with our nurses, with peer mentors and navigators, community health workers. We really need a multi-pronged, multidisciplinary, interprofessional approach to really advance trauma-informed care, patient-centered, respectful care. And so I end with some policy directives. You know, of course, we need better clinical practice guidelines for our clinicians, but we also need to make sure that we are working with our school nurses and our social workers and behavioral health practitioners, working with child protective service workers and law enforcement. There needs to be better guidelines on mandatory reporting and addressing a lot of the ethical conundrums, some of which we've touched upon today. There's been a lot of effort to increase the library of resources on educational and surgical photos and videos, and I'll show you some links shortly. And of course, we need better funding, especially in this current environment that is a massive threat. And that's where we really need to lean into how do we innovate in the space in terms of partnering with philanthropy, with community organizations, to public and private foundations to help amplify the importance of this work and advance support and funding to continue and promote work in this space. And it really requires a community of all leaning in and working together across our various spheres of influence, whether it's at the governmental level, policy level, the community-based organizational level, across our educational institutions, our schools, our healthcare institutions, over the media, right, other social service agencies, and how we work together in optimizing quality, culturally and trauma-informed care. I'm going to make sure that you have all of these slides, but I just want to briefly just showcase at the end of my slide deck, I have a list of resources, one of which is the US End FGM Network, which is an amazing national repository of resources linking communities and providers across the country, which is a forum for resource sharing, but also education that we're so lucky to have the executive director based here within our Commonwealth. There are some self-advocacy tools that Johns Hopkins School of Nursing has been able to do that helps empower patients when they go and receive care. And this is also on the website, the NFGMC network website, for empowering individual patients when they go and seek care. There are other resources which you see this QR code here, but also I'll make sure that these slides are fully available that provide amazing resources for patients. There are educational resources where you can change the skin tone and the appearance of the vulva to educate patients across the different types of cutting that they might have. There are some resources for reliable statistics of this ever-changing landscape. The World Health Organization has a resource, a really excellent go-to guide for clinicians. My colleagues in Europe, Dr. Jasmine Abdul Kadir, led an effort to create the first ever pediatric atlas in terms of caring for children and adolescents, which is amazing. And it's also open access, freely downloadable. Was a great resource. And I was part of an effort through the American Academy of Pediatrics to update their clinical guidance a few years ago on caring for girls and adolescents. And then my former academic institution is Arizona State University. We created a resource guide that's freely downloadable. I have physical copies of these posters that for anyone who's interested, I can absolutely give you. I have hundreds of these that I can share with anyone interested, and you can scan that QR code to be directly linked to the downloadable resource guide here. And of course, there's online resources, videos for clinicians who want to understand more of the surgical techniques. And of course, THAHEO, with their amazing digital storytelling. This is the link and the QR code to see their entire repository of these videos. I just shared just a few today, but just so impactful and so important to really centering the voices of community and the voices of affected women and their families in anchoring this work. And in addition to THAHEO, Sotieto and Sanctuary for Families are based in New York City. It's just one of many organizations across the country really advancing important work supporting women and families across the diaspora. So I want to thank you so much for your time. With whatever remaining time we have available, I'll take any questions that you might have. And again, this, of course, we were recording this talk, but also the slides freely can be shared with our community. It really disseminates greater education and awareness and trauma-informed approaches to better serving our community, not only here in Central Massachusetts, but across the Commonwealth and nationally. So I'm just so thankful for your time and allowing me to spend some time with you, increasing awareness about this crucial practice. So thank you so much.
This was amazing. Thank you so much. I really didn't know. Like, there's so much that I didn't know, and it really was so educational. I see that Alex already has his hand up, and Alex is, of course, our most favorite immigration attorney, star of Worcester. It's just so glad to see people that can really benefit from knowing about this here on the call. So thank you, Alex. Go right ahead.
Thank you, Amy, for putting this together, and Crystal, thank you for this presentation. It was so comprehensive and raised so many questions I hadn't thought of. The biggest one I'd want to focus on is something you mentioned about the type 1 cutting and how even seasoned practitioners miss this.
Oh, yeah. Sure.
And that really got me thinking about providers, legal providers, other providers. And
Mhm.
there's another piece you had mentioned about making sure that we're starting this conversation in a culturally competent and informed way. I mean, ICE handing out pamphlets at the airport would be the complete opposite of that.
Yeah, right.
Are there any really literal best practices that you could share with us about how to start the conversation without doing it in a way that would be more harmful
Oh,
than helpful?
excellent. Absolutely. Thank you so much, Alex. And I just want to lift you up with the amazing work that you're doing. I'm just honored to be partnered with you in this space to advance culturally informed care and support for these communities.
It's
But
mutual.
yes,
Thank you.
yes, but yes, you raise such an important question. I think every single time I give a talk like this, that's one of the first questions, like, how can we be culturally informed? Oh, and this is how I approach, even when I talk to medical students and residents about this. You know, I really take a universalizing approach. You know, one, at least having a general familiarity of the regions of the world where this is practiced. But then, you know, similar if you were talking to someone, you know, at risk for or concerned about domestic violence, right? Or some other kind of harm, you want to not pass judgment, but just say, you know what? I recognize if you know, okay, where they're from or, you know, anything about their cultural history, etc., you could just acknowledge, and that's part of cultural humility. I recognize that you may be from a region of the world where there are many communities that practice female genital mutilation or cutting. Is this something you've even heard of? Is this something that you even identify with or strikes a bell? I mean, we're just talking broadly. Is this something that even you might be familiar with? And just see what they say. You know, and it's one where you can open yourself up to, let me learn. Help me help you. I am eager to learn, what does this mean to you or your family? You know, without before it even comes down to, are you affected? It's like, is this something that you've heard about that is even something that has been a part of the communities you've been a part of, or what about in your own family? And depending on what they say, you might then drill down to, is this something that you might be personally, you know, identify with, whether you've directly impacted or someone close to you impacted, and just see what they say and just be very open-ended in a non-judgmental way. And also, as I said, level setting on terminology. Maybe it's not mutilation. Trust me, when I went into the community in Columbus, Ohio for the first time, when I was very early on, just trying to forge a research program around understanding the needs, I absolutely could not use the term mutilation. They were like, oh, if that's what you're going to do, we will not talk to you. They made it very clear, we are not about to air our dirty laundry, right? And so, you know, very early on, I learned I need to make sure I reflect what is normative among the community so I can earn their trust, so I can be able to have honest conversations that's open, non-judgmental, and I'm here to learn. And taking that stance, I think, goes a far way in one, being able to break down some of those walls and barriers and just set yourself up in a humble way that, you know what, my patients or my clients can be the best teachers of their culture. Despite all my education and my own study on this, it doesn't matter. What matters is the patient's voice and the family's voice. And I'm here to learn. And they can be the best teachers for me to then be able to see how best I can help them. Really make it patient-led or client-led, client-directed. And again, you might not be able to even have that conversation on that first visit. You might talk about other things. And maybe you could just say, you know what, we might not have time for it today, or maybe this might not be the right setting, but I'm here, and maybe we can table that for another discussion, because I know, especially in the clinical realm, we're so taxed with time. We only have 15 minutes with the patient, and sometimes we try to cram too much in, or the opposite. We hone in, oh no, this patient has FGM. Everything becomes about that. And it's like, that's not why they came in. That's not even on their radar, so we could also take it the other way. The pendulum could swing and we're just like aggressively, I need to get this information. I'm like, no, you don't. Right? If that's not what brought them in, we can table that until another time where it's comfortable for them to bring that up. Or maybe they might prep and say, okay, next time, if you're comfortable, perhaps we can talk about this, and they might have time to mentally prepare, because this could be psychologically triggering, because this was perhaps a very traumatic event, right? And how are we precipitating PTSD by now forcing the issue when they're not ready or willing or even feel safe entertaining those conversations? So I really take a very much patient-led approach of like letting them be in the driver's seat. And if it's not the right time, it's not the right time, and that's totally fine. But I want them to know is I am here to help you in whatever way you would want my help. And just establishing that environment of trust and safety goes a far way of being able to have more of those meaningful discussions further on. So I hope that helps.
So that was
Alex and
helpful.
everyone else to help
very
ground
helpful.
how can we take a culturally informed and a humble way to elicit trust and
Yeah.
earn trustworthiness to engage deeper.
Yeah, it takes time. Thank you so much. That was great. Thank you, Crista.
Mhm.
Other questions or thoughts? And Krista will put all the resources on the web and all I really love the media you used too. It was so helpful to just have empathy for both sides of the equation too, right? Like I feel so naive and like ignorant about what people have been through and what has happened. And so, I was able to really empathize with the provider who does not know what they're coming upon, but also the person who's so vulnerable and has a provider that they don't have a relationship with and isn't sure how this is going to go down or how to talk about it. And it really is so important to have these narratives because don't know how to talk about it. It's really hard, really intense. And I also appreciate that you grounded it in the much larger context of racial justice, gender-based violence, the sociological pieces that are just jumping out at this moment in time more than ever before, the intersectional nature of this trauma.
Absolutely. No, thank you. If anyone's interested in that intersectionality, that's what I've been writing about most recently in my publications in terms of really, this is a flashpoint of communities that are already under siege and targeted because of other identities. And now you add on this piece and you can just imagine that emotional burden of having to navigate care where you're navigating all these other tensions. Yeah, the need for a trauma-informed approach is paramount. So thank you for amplifying that point.
Sarah has her hand up. Go ahead, Sarah, jump on in. Thank you for being here.
Sure. Thank you so much, Krista. It was really such a well done presentation, and I loved your perspectives and the different media you included as people have shared. Coming from the behavioral health position, I'm wondering, well, my first question was around group support. If you know of any resources or examples, if that is helpful, if that can be more stigmatizing. I imagine it depends on the community and just different sort of needs or perspectives that people might have, but wondering about any kind of insights you have on that piece.
Yeah, no, thank you for asking that, Sarah. And obviously it's context specific, but I think there's a lot of value in group support. I know in my work in the past, leading focus groups, I feel women have really rallied around shared experiences, that they're not alone, because this is often so isolating, because you feel as though, well, one, you don't really talk about it. This is not something that you just freely talk about in your family, in your community, right? I've actually, even within couples, the reason why I'm such a staunch supporter of bringing in the partner is because even in coupled relationships, there's often no discussion on it. I actually had a Sudanese couple who I was counseling regarding defibrillation during childbirth, and the husband literally started shaking in front of me. Like his whole body literally started shaking. And he acknowledged, you know what? This is the first time in his entire life that he's openly talked about this practice and what it means to him, his partner, their relationship, because they were not able to have penetrative intercourse. They had type 3. The wife was adamant that she wanted to be re-infibulated after delivery. Like this was something she couldn't imagine not being reclosed afterwards. And we had a long discussion about that. But the fact that we brought in the male partner voice was so powerful, because he absolutely was a staunch supporter of his wife and was just like, I want the best for her. I'm concerned about her pain. I believe that they can finally have intercourse without pain, after childbirth, right? But also talked about, well, what does it mean to have your scar put back together versus leaving it open, and never having an opportunity to have any discussion. And in the US context, oftentimes what actually happens in healthcare spaces is that those conversations don't happen. In fact, these women undergo a C-section because it's easier to just do a C-section and just forget about the vulva because it's just too complicated and it's cultural. And you just do a C-section, which is why in the US and also other countries, the C-section rates are alarmingly high in this community. Why? Because these basic conversations are not happening, because we as clinicians are not comfortable leading these conversations, what to say, right? And so I think there's value in group therapy and shared lived experiences where women can draw strength from other women who might be experiencing the same thing, but they've never had an opportunity to actually have real discussions as to what this means. And I found that it's been so invaluable to women that I've been able to be a part of these kinds of engagements in a way that, as long as it's safe, it's trusted, it's they're in the driver's seat in terms of when, how, in what context. Does this happen in a home? Does it happen in a medical space? What's desirable? And really leaning into supporting women coming together in these groups. But the ones that we've led and done have been powerful. I've done some around sexual health and sexual pain and genital sensation. Amazing. We actually used dolls and like anatomically correct dolls to like illustrate, dolls that actually had like, genitalia, and we had a vulva puppet so they could look and see, oh, this is the clitoris and this is what it does. Like having that hands-on, but in an intimate small group where women learn from each other and hear from each other is empowering, because you find that they will find their voice where they felt like, oh, they were an only. And like, oh, no, you're not alone. Many other women have the same thing, but yet they're not talking about it because those spaces haven't been nurtured in a way to provide credible medical information in a way that is not just instructive, but in that space of community fosters openness and dialogue in a way that can't happen with just one-on-one with a provider per se. So I think there's so much strength, and I'd love to be able to work together here in our Worcester community, Central Massachusetts, to be able to cultivate that. We have this 5-year grant that we're just starting. We're just in our first year. So I'm hoping this is just the beginning of us being able to nurture those safe spaces in the community within our health spaces and supporting that multi-pronged supportive. We need school nurses, we need social workers, we need, our immigration attorneys. Like these are the supports and pillars that we need to surround the community in, so that there's safety and inclusive environments where we can promote health and wellness in a way that resonates with communities without further causing harm or trauma. So thank you for your question. And
Yeah, thank you so much for sharing. That's
yeah,
really helpful. I think it's not something we're seeing a lot in the clinic setting right now, but I think part of that is that we don't know what we're looking for and we don't see what we're not looking for necessarily. So really, yeah, this was really helpful and definitely might reach out about opportunities to collaborate. Appreciate that.
Absolutely. Absolutely. I will make sure that my email is in the chat for anyone who wants to reach out. Please do, because this is exactly and precisely what we want to do.
Someone did put a question in the chat, and feel free to unmute yourself and ask the question, or we could read it out, which I'll give you a minute and we'll go from there.
Yeah, I was more wondering, when am I going? Oh. Hold on.
I can read it if you'd like. The question
Sorry.
is,
Can you hear me?
yes, go right ahead.
Yeah, I was just curious, do these women acknowledge that this was like a traumatic thing, or is it just accepted as a normal cultural experience?
It's the full gamut. I've seen the entire spectrum, literally, all of the above. It's so individual specific. And that's the beauty of it, because it's so important to meet women where they are, regardless of their embodiment or understanding. Seen it all. So yes, for women who experience this as absolutely traumatic, 100%. I acknowledge that, and we seek to get them plugged into the necessary resources and support, whether it's legal support, whether it's psychological support, that would help them in better coming to terms with it, as well as how does that now position the ability to move on, whether it's a new relationship or whether it's now navigating school or what have you. And on the flip side, I've had patients who are staunchly supportive, but they will defend, like, I am so proud of my circumcision, it identifies my identity. In fact, I've had patients who say, I don't want to be like you, American women who are open wide, flapping in the wind. I've literally had patients tell me that, view us as like, we're horrific. They actually prefer them because they feel protected, they feel clean, they feel pure. And guess what? And that's fine too. And so, again, no judgment. We meet them wherever they are. And how can we best support you? But also provide education. I find that for myself, when I'm in the examination room with the patients, I always have a mirror, because women often may never have actually looked at themselves and identified, oh, this is what I have. I have an actual laminated guide with actual photos. So after my exam, I was, hey, let me give you the mirror so you can look for yourself, and let's show you this is what you look like, and this is the category and type. And that is so empowering, because women didn't even know. And I've also had the flip side. I had a young adolescent who was like 16 years old, whose mother swore up and down she was never cut. Nope. She basically lied to her whole life. And sure enough, came in to see me. She actually had type 3, was having menstrual issues. And lo and behold, when her mother was with her in the room, her mother acknowledged, oh yeah, I lied to my daughter her whole life because I wanted to protect her, because I couldn't protect my daughter from undergoing the practice. So that's why I hid the fact that, confiding in her that this is what she actually underwent, because she was too young to remember the procedure. Lo and behold, I ended up doing a defibrillation surgery. She did fine, and healed well. But lo and behold, she became suicidal because of the PTSD of the fact that her mom had withheld this information from her whole life. And she only found out as she's seeking medical care to address a clinical physical issue, knowing that her mom confided that, yeah, what I had said all that time, I was lying, like, you were actually cut, but I was trying to protect you because I couldn't protect you because it's so deeply part of our culture. And so, of course, we got her plugged in to behavioral health, right? And So, I mean, I see the full gamut. And it's honestly comes back to meeting women wherever they are on that spectrum and supporting them, empowering them, centering their voice, providing education as needed, showing them through images, a mirror for they can see for themselves, or whatever it is that will help them in their processing. And I even have women who are conflicted because they are happy with the decision to open their scar surgically so they can finally have penile vaginal intercourse without pain. So they're happy they went through the procedure to open their scar. But on the flip side, they're struggling because they don't like their genital appearance. I literally have had patients who struggle with their genital self-image, and they're like, I don't like how it looks afterwards. I don't like the fact that I'm open wide, but I'm happy that I now can have sex without pain, right? And they're living in this duality of like, I don't have pain, but I don't like how I look. But I don't have pain, right? And how are we supporting these women, right? There's so much needs to be done in terms of ongoing psychological help and support and therapy, right? So there's so much, and I feel as though we're barely scratching the surface, and which is why I'm such a staunch advocate for holistic, multi-pronged approaches to care that addresses the legal aspects, addresses the cultural aspects, addresses the physical, psychological, emotional, right? To better support their journey to their own health and wellness and the embodiment of what this lived experience means to them as an individual, right? So I would welcome anyone interested in partnering with me and within our community to build this, right? Because I think we could truly be an exemplar for the nation, because this does not exist anywhere in this country. The only place this comes close is my colleague Jasmine Abdul Kadir in Geneva, Switzerland. She has a practice which is the gold standard for the world, where she does just that. It's interprofessional, it's multidimensional, it's strong partnership with community and clinical partners across sexual health, physical therapy, clinical care, surgical care, right? Behavioral health. But that does not exist in the United States. And I did work in the space for 15 years in Arizona, but it was disjointed. We were not all in one space. We were like, refer them somewhere over there and send them over here. It was not co-located in one space where I can do a warm handoff. Okay, I finished my clinical assessment and let me introduce you to my colleague, Alex, right? Who will now talk to you about your immigration legal concerns, or we turn it over to our social worker, or turn it over to our behavioral therapist, right? That's the gold standard. That's where we're moving the needle forward in trauma-informed inclusive care. So I feel like, if we could create that here in Central Massachusetts, we would truly be an exemplar, not only for the region, but for the nation.
Go ahead, Alex. Jump on it.
Yeah, sorry to jump in because I know we have such limited time, but I totally think that is so true, and that goal you have, Chris, is a great one, and I look forward to working with you on this as we go on. One piece that I thought was so informative about your presentation was the ongoing nature. I think of the harm, the misconception that so many people have and that the law has about this type of harm as a discrete act, when you've made very clear that the ongoing medical needs are profound, and then the psychological outcomes and the conflicted feeling that individuals might even have about the harm that was perpetrated. It's very much misunderstood in the law, and this presentation made me even understand some different theories about how it's ongoing, because the way that asylum law works, there are circuit courts that are saying, well, if the act has already occurred, then there's really no possibility of future harm. Thus, the asylum claim might be cut off. But there are some circuit courts that have pushed back on that. The Board of Immigration Appeals is an interesting case on this. It's called Matter of AT, if anybody wanted to look it up, but it talks about how that past persecution, to say that that's past persecution, there's no fear of future persecution, is really essentially double penalizing somebody for the fact that the harm that they endured and pretending that it's not ongoing would be penalizing them unduly.
Mm.
But it's still not clear. And it was so interesting when you talked about these other lawyers who were saying, well, the fear has to now be for daughters. And I get that argument. It's just so unfortunate that we don't have a more educated judiciary and legal community and Homeland Security Department and Asylum Office to understand that the persecution continues after the event, the initial event of the cutting. So I thought that your presentation really shed light on that and talking about all the needs for ongoing care, physically, psychologically, sexual health, all of it.
Yeah. So profound, Alex. Thank you so much for raising that. Actually, you're the first person on all these presentations that I give on this topic. Like, you're the first person that really kind of like honed in on this. So thank you, thank you, thank you. And I'd love to work with you on that because it's 100% correct. I like to anchor it around harm prevention, right? Or harm reduction, right? So obviously primary prevention, we all know what primary prevention is. Preventing of girls, right, from undergoing that first cut. Obviously, that's a human rights issue. There's, you know, a minor who is unable to, who has no autonomy, no informed consent, that is a human rights issue, period. So primary prevention is what it is. We all understand that. But secondary prevention is what you talk about. It's those women who've already had that first harm, right? But how do you support them because they have ongoing psychological and physical impact, right? Whether it's sexual health, whether it's reproductive health, gynecologic health, the list goes on and on. Ongoing impact. That's secondary prevention is how do you provide the supports to support their ongoing health and healing and wellness, right? Then I want to introduce tertiary harm. That's that quadruple jeopardy that I talked about. And my research has uncovered that. I actually have quantitative evidence that yes, there is a quadruple jeopardy of that intersectionality of race, gender, religion, migration, right? What's happening now that women with their intersectional identities are navigating care and are being othered because now they're singled out. Why? Maybe they're wearing a hijab. Maybe they don't speak any English. Maybe they're uninsured. Maybe they have very limited health literacy. Now they're entering a clinical space and they're further othered because, oh, they have this genitalia that no one is familiar with. Let's bring in all the medical students and residents to go peer at her genitalia, right? You know, that's tertiary harm because now she's exposed. People are peering, prodding. You saw all those personal stories that I shared, which are so profound, right? That's tertiary harm, the othering of bodies, the objectification of bodies, which when you look at structural racism and the history of how we've been experimented on, Black bodies have been experimented on, right? You know, we perfected surgical technique on women without anesthesia. Right? These are the tertiary harms that no one talks about. I was literally the first to kind of put the two together, and I can send everyone the paper that kind of detonated that bomb a couple years ago, where I kind of put that out there. Like we are affecting tertiary harm on populations who are already wrangling with being target for deportation, right? Who do not speak English, are already navigating complex health systems and have all the social determinants of health that are bearing on them as minoritized individuals and communities. Now they have this cultural marker that sets them apart for further stigmatization and harm because clinicians don't know what to do. Deer in headlights. What do I do? I don't know. Right? Now they're getting that C-section because it's easier to just cut and take the baby out rather than have a conversation about how do we manage your scar and what would you like done and how can we help you, right? So that's tertiary prevention. So I love where you're going with this, Alex, and I'd love to be able to take this to the next level to how do we become that best practice model of intervention that's trauma informed, that's not perpetuating those harms. And yes, we need to talk about all those kinds of prevention, primary, secondary, and tertiary prevention of harm.
Totally. It's great.
So thank you for literally the first one in like 30 years of me being immersed in this that has kind of brought that to crystal focus.
It's a huge
amazing.
issue. It's a huge issue in the legal world right now because those types of tertiary harms are really what go to humanitarian asylum, which is really a separate branch of asylum law. that's separate and apart from any fear of future persecution. There are instances where the past persecution was so bad, or the other harms that might occur in the country of origin, unrelated to the initial harm, could be so serious that the person warrants remaining in the United States regardless of the specific future fear, or regardless of a change in circumstances, which some adjudicators are finding that once the FGM occurs, that the circumstances have now changed because the harm has already occurred. So there's no future harm, which is problematic in its own right. But it's a field that a lot of us are also working on our end of humanitarian asylum, and the lack of awareness around what you've termed tertiary, or you've indicated are tertiary harms. And I think there's definitely an overlap. So thank you for sharing that.
Alex, you are exceptional. We appreciate that you kind of put all that together. I was thinking too, when you were saying it about C-sections, we had Sharice Hamblin from your team do a Trauma Training Tuesday on Black maternal health outcomes. And I had not really thought at all about how those things intersect until you said like, wow, they're going to go with a C-section. And that makes so much sense, and also speaks to ongoing, like, lifelong harm that can come, right? If it's going to impact your healthy ability to have a healthy pregnancy and a healthy delivery, ongoing harm.
Absolutely. 100%. Yep. Thank you for elevating this. This is absolutely crucial.
It's also, was thinking about how cross-sectional women's sort of being turned against their own bodies and their own physicality, and worrying so much about how they look in their appearance, how that is sort of germane to being female, and to see how this really plays out in other countries and other cultures in harmful ways. We know how harmful it is to white American women to be body shamed at so many levels. And it just really speaks to the different experiences we're all having of oppression and harm.
Yep, absolutely. 100%. Yep.
Does anybody else want to say anything or ask anything before we kind of wrap up this very powerful and important topic?
Amy.
Carmen, jump on
Hi.
in. Hi.
How are you?
Good.
I want to ask something. I want to ask, how do you deal with a young girl that is going with parents issue, and she's cutting herself behind the parents? When she goes to the bathroom, she cuts herself.
So are you talking about self-injury?
Yes.
Yeah, that is a huge, big topic. Krista, I don't know if you want to speak to that at all, or if that feels like it's a little bit of a big opening for a last question.
Yeah, I don't know if anyone here who has experience with this directly, since I personally can't speak to it from my own experience, but I'm sure there must be providers or professionals that can expand on this more. I mean, obviously, I would imagine bringing in behavioral health supports ASAP, but I welcome anyone else who might have some insights that could answer Carmen's question.
I can find some resources for you and give you some support on that issue.
Please do.
It's a
Please do,
common.
because I got somebody close that's doing that. Having problems with the father, having problems with the mother, the one who's taking care of her. You know, she still lives with her father because her father doesn't want to let her go. But he's doing things that he's not supposed to either in the house. And she's seeing, you know?
And the do include all the family dynamics. So it really is, it's a good point to think about. And Krista brought it to the surface a lot, that this is impacting young women and their parents and their partners and their siblings. And people in their life. So it's a bigger question than we have time for right now, but thank
Yeah.
you for asking that.
Yeah.
Susan, go ahead, jump on in.
I'm sorry. I know that we're right at time. Wow, amazing and horrifying. The picture of the white feminists, I just like can't wrap my head around,
Mm-hmm.
you know, and it wasn't that long ago either.
Mm-mm.
It looked like it had been recent. My question, and you may not have time to answer it, is that I was wondering, is there, you know, what's happening within the medical schools or school to educate new doctors? Like, is this a priority? Is it even on the agenda?
Woo. Thank you, Susan, for just elevating this, because I've been on the soapbox for at least 25 years. Woo, without a mandate, without a funded mandate, it's like poof, right? So I would love to work with anyone motivated to do this, to even, let's start at UMass Chan, where I am, not even 2 years, you know, to try to see how can we make some important inroads among our medical and nursing students to raise awareness. How can we embed this within our curricula? I've already made inroads among our professional organizations. Like, I'm writing the guidelines for the urologists across the country. So with their maintenance of certification, they can be reading and learning about FGMC so that they can maintain their board certification, right? But I feel like we need to start earlier, and definitely at the graduate school level among our nursing and medical school learners. And I would be thrilled to work with anyone to kind of put together curricula that's interdisciplinary, that will bring in the crucial interprofessional voices on supporting this community and educating the future clinicians and scholars advancing this work. So that is fundamental. One of the biggest barriers over these decades is the follow through on educating the next generation of clinicians and scholars on culturally informed, trauma-informed care. So yes, if that's something that my time here could help activate and then be an exemplar again for other medical schools and nursing schools, I'm in it. I'm down. And if there's we could coalesce a small group who are very much invested in pushing this forward, I'd be happy to be engaged. And we're not alone. I have colleagues across the country. I have a colleague at UCSD right now who's trying to do the same thing. Like there's a chorus of voices that have been demanding better accountability at the school level for decades. Yeah, till we're blue in the face. So I would love to help mobilize something, and it doesn't have to be medical and nursing school, social work school, right? Any other interprofessional school, you know, where we can kind of work together to thread the needle. That's what it requires, especially at times such as now. We need to be interprofessional, interdisciplinary, to really see the kind of inroads that we want to see, that we seek. That is addressing the social determinants and structural forces at play that continue to stigmatize and marginalize vulnerable groups, this being one of them. There's so many lessons. I mean, this is 101 on patient-provider communication. This is not rocket science. A lot of the pearls that one learns applies to working with any vulnerable population. Respectful care, careful listening, non-judgmental. I mean, these are fundamental approaches to being a good clinician, regardless of your field or discipline. So I feel like these are crucial pearls, whether we could be woven into the curriculum somehow. As for starters, I would be all for it and would be happy to work with those stakeholders who can help push this forward. We're not starting from scratch, and I think it'll be a low lift if we get the institutional buy-in that this is important. So I'm happy to work with any partners wishing to kind of take this on. I'm all in for it.
Thank you so, so much. We're so grateful for your time, for your presentation. We have recorded it. We'll share the link as soon as it comes back from Zoom. And like, let's all work to further this mission by getting this information out to people. It really, I had no idea the depth of what I did not know until today. And I'm sure that's true for many social workers, doctors, community health workers, people that care. And you know, this is free information. So let's get these resources out to people and get this information out to people that can really do a better job helping people in need. Thank you so much.
No, thank you so much, Amy. And thank you all for your amazing questions and your engagement on this topic. It's absolutely fantastic. And I would love to partner with you. Anyone interested in taking this further, please. I already put my email in the chat. We have a 5-year grant that we just launched with Saheo and the NDFGM network. We are just beginning, but I feel like this is the coalition building that we must do. This is the groundwork that we must do to begin to move this forward. So I'm just really honored and humbled to have had the space and time to share about this important work and issue. So thank you so much.
Thank you all so much.
Thank you so much.
Bye.